to present on behalf of Dr. Cayetano.
Blessed good morning. I am not Dr. Cayetano, as you see in your...
You want to come up? Yeah. Do you have a visual presentation? Yes.
Yes.
Okay.
I'm using the slides of Dr. Cayetano, still to get you some of the information of the Pan American Health Organization, PAHO. And as you see, her topic was to talk about the challenges and the opportunities in the Caribbean, now that we have the PAHO plan and we have the WHO Global Dementia Response. If I can see, add this. No additional hole? Okay, then without, no problem. I got an email from Dr. Cayetano, and I want to share with you in her own words. Dear Raymond, if you can discuss the relevance of the PAHO strategy and plan of action with the participants, that will be of great value. The time frame of the strategy is 2014-2019. Not much time is left, and time is of essence. We need to encourage the participants to engage in the formulation of their own local plans. Each country has its particular needs and resources, and therefore their plans need to reflect that. The message that Dr. Cayetano wants you to take away is this. It is so important to prioritize dementia in the Caribbean countries. The message that I would have liked to deliver, she said, is that participants need to be cognizant that their ministers made a commitment at the PAHO Directing Council, that was in 2015, to adopt the strategy, and the countries now need to be made accountable. That's what we did yesterday. The minister came, the president came, and they repeated the commitment that Trinidad and Tobago here made. And through these minister and the president, we see all our ministers of health of the region, because they all, as CARICOM, were the last ones that said yes to the plan from the PAHO. So, to keep them accountable, this is what Dr. Cayetano tells us from the PAHO. It's we, as participants, have to do that. Participants need to have clarity of their role as advocates to place dementia on the public health agenda of their countries. Please feel free, she told me, to provide my contact information if they have questions. So don't ask me nothing. I will leave all her details for you so that you can ask her about slides she shared with me. And of course, we will have a productive conference. So the recommendation of the WHO, World Health Organization, in 2012 in their report, Dementia, a Public Health Priority, was picked up by the ministers of public health. They made a commitment in the PAHO plan from 2015 for 2019, and we are now in 2017, and in September they have to evaluate how far they reached. And the World Health Organization, last week Monday, adopted the global response. That has a time frame of 2017 to 2025. Is there a national plan in your country? We can already answer that. Caribbean, not yet. The non-Latin Caribbean, I see. The PAHO Mental Health Advisor said, encourage the participants to engage in the formulation of their own dementia plan. How shall we do that? Yes, each country has its particular needs and resources. So, doesn't matter from where you come. we are so happy that you are here because the plan that you have to prepare in your country, that you can influence in your country, will have commonalities that we can share. So the question for you today will be, what do you want to see in your national dementia plan? And that's in the afternoon workshop. So to give you some of the ingredients that you can go back to, this is of the PAHO plan. Mark already referred to the goal. The PAHO said universal access to health. Everybody must get health care. Universal health care coverage with quality interventions, especially also for persons with dementia. In order to help them to recover or to maintain their functional capacities, to prevent or avoid dependence, and to improve their quality of life and the well-being of their families and of the caregivers. So, the principles that in the PAHO plan will be addressed: universal health coverage, human rights, evidence-based practice, the life course approach, the multi-sectoral approach, ethnicity, gender, and equity. Not to lose too much time, just to tip you, I'm going to compare for you what is in the plan of the PAHO and what is there in the plan of the WHO. And life course approach is in our PAHO plan and not in the plan of the WHO. And what does that mean for us? It is not only talking about people that are affected, but also talking about the rest of the society for them not to get affected. And that is not only when you get of age, but it starts all from when you were born. How you will be fed, how you will be nurtured, how you will be living, because these are all factors that have an influence in getting dementia or other non-communicable diseases. And that is item of ethnicity and gender. In the world, we are not all the same. We can have different cultures, we can have different people, different races, all of that should be taken into account. You will hear about that tomorrow when Dr. Schiff will address why it is that in the Caribbean we have to do research that is more specifically looking at different ethnicities in our communities. Don't go to tell you what he's going to tell you. The strategic lines of the action that PAHO said we have to develop are to promote the plans and policies and the programs that promote and respect human rights for persons with dementia, their family members. Establish interventions in the health system and in the health services networks. Implement quality long-term care system. Development of human resource training, and improve the research and the surveillance capacity. What is meant with surveillance is that it's not only look at the diagnosis for the person, but follow him and follow how the development will go. And we need those kind of data for you to adjust your policies. So to promote the plans, why? And why to respect human rights? The NCD plan addresses, in every country right now, and the Caribbean was front runner, the risk factors for non-communicable diseases. So that's a good plus. But for dementia, we have to be more specific, maybe. So research must help us there. And we have to promote a plan that they also can be respected in that area. Prevention, brain health. How to maintain your health of your brain. How to promote that you can improve the health of your brain. And if you are challenged by a dementia condition, what can be done to restore the brain? To reduce the reduction of dependence, we all have the right to autonomous living, which means that we can decide for our own what we want to do. What we see with persons with dementia is that a lot of time, other people is going to decide for them what to do. And that brings a lot of time friction, because the person still has the wish, still has their desires, still has to be respected in the decisions that they want to take. The provision of dementia care at home and in dementia care institutions, the plans must be there to accommodate all of that. So the power plan speaks about objectives to be reached for 2019, it's 2 years from now, and with indicators. The important takeaway that I will give you right now is this. For the PAHO, they look at the 42 member states, and then they say, right now, for instance, the number of countries and territories that have a policy plan and or a program on dementia is 7. It was 2 years ago for the whole Americas. So what they want is for 2019 that there will be 5 more, 13. That's a very conservative decision of the ministers of health of the region. It's still not the majority. It is still not all. So that is where, with the request of Dr. Cayetano, we have to be advocates for our government to be in the 13. And if we all do it, then it will not be 13 that they achieve, but they will be achieving all from the Caribbean. So, very important that we can get there. And how can you influence now what should be in such a policy? For instance, if we talk about human rights approach to reduce stigma, how is your experience to tell people about, but people with dementia, they are not crazy. People with dementia are people just like we. They have their wishes, they have their things. So these kind of elements, ingredients, you can bring them up in the afternoon session, so that they are in the plan and they can consider it and they can take away that also. So we all are important to help formulate what should be in the plan. Interventions for prevention and for quality care. Well, we who have some experience in dealing with our loved one with dementia, we know what we got as services. So the best people to tell government what to do, for others also, and we included, to get a better service in the system, better quality care, tell it them. And you see, the power plan says with so many words, we must get multi-sectoral integration, as well as the involvement of the community, the family, the caregivers, and the persons with dementia themselves. So what will be the interventions for care? Protocols of clinical management, how to deal with a person with dementia and how we go about it. How are we going to treat them? Are we going to sedate them, just give them the drug that they can surf being there? Or are we going to give them more treatment so that they can be fully participating in meaningful activities? And how we go about it? So these protocols have to be established. And when we come in a healthcare institution, we know how it is. But when we come at home from a person with dementia, we also see that much more can be improved. So what should be in the plan to help improve that? How the care for a person with dementia will be improved. They say that they want to see plans, not in 5, 4, 7 countries, but in 15 countries by 2019. They want to see quality long-term care. That's institutional care. To address the needs of dependent persons, their families and their caregivers. But they want to see it based on a primary health care approach with a respect for human rights, gender equality, treating men and women equally, and with equity. let me take the one of gender equality. The PAHO plan says, we know, and Dr. Cayetano brought it up, family and especially women, they have usually been the main providers of long-term care. They have to leave the job, they're not getting any income, and they have to do voluntary work the whole day, and sometimes 24 hours a day. So you won't have enough of those people if the figures are increasing. So what shall we do? What should we do? So most countries must come with a plan to address it. But they don't have resources. They don't have the infrastructure to ensure long-term care for supporting caregivers. And when we look at the rich countries, we see that they had a summit 2 years ago and said, wow, we can't pay anymore for long-term care. We have to come up with a solution. And so they have stepped up now looking for the cure. But still there will be people that need care. And so, what about the support now to stay at home? The PAHO wants to promote that will happen instead of bringing to the institution. How shall we go about that? And especially you that have that experience, this afternoon you can say how you would like to see that. What are the suggestions that you have for the plan that care at home can be available, that you as a caregiver can get more respite, that you can also have your life, and that you can get support, that you can get help. What are the things that you see that you would like to see, what you're not getting right now, that it will be something in the plan that will be developed and that the countries will have that, so that community-based programs and services to support the elderly people and the caregivers with dementia can be facilitated. Instead of 5 countries that have a plan right now in the Americas, they want for 2019 that it is 15 countries. Support for caregivers. The number of countries that already have programs and interventions, training to address the rights and the needs of informal and the formal caregivers. When they say informal caregivers, they mean all those unpaid loved ones that are looking after the person with dementia. And when they talk about the formal caregivers, they talk about all those healthcare professionals, nurses, whoever get paid to help. In 12 countries of the region, they have a plan. They want to see that this will increase to 25 countries. But remember, it's 42 member countries. And from a human rights approach, all these caregivers that are helping need support. And it's not only in these 12 or 25 countries. So again, take out from here, let us go back and let us activate and get it done throughout our region, so that the 32 countries and territories of the non-Latin Caribbean, that they all will have plans to support the caregivers. Evaluation of the institutional care. Number of countries and territories that they want to see with a system to evaluate that, an audit system, and looking at the quality of the care, what are the standards, how are the rights of the people in the institution protected and respected. Right now they have that in 10 countries in the plans, and they want to double it to 20 countries. 2 years from now we must have that. But aren't all the persons in an institution, aren't they all entitled to be respected in their human rights? So this is for us to see that we must be advocating much loudly and much insistently to get it throughout the region and throughout the continent, and hopefully also throughout the world. Training human resources. When we talk human resources, usually people think of paid people. But all the caregivers at home, unpaid volunteers, they should be getting training too. And that is in the plan of the PAHO too. So how to go about it? The PAHO mentioned a few obstacles. For instance, obstacles that people with dementia and other disabling conditions have to deal with. The stigma surrounding about dementia. People think that they're crazy. They're not. Bad attitudes, lack of knowledge and understanding about dementia, lack of competencies of healthcare providers, communication barriers, because sometimes they lose their speech and then how to get the message across, and insufficient for information about their rights and care services available. So to address these things, you might have some suggestions and ideas. Bring them up in the workshop later so that that can become part of your national plan. Training undergraduates and graduates, very good thing. In 0 countries this is happening in 2015, and they want for in 8 countries that is already starting. So you see they're very conservative in the objectives and in the indicators if we are reaching the objectives. Research and surveillance, it is still limited the information for decision making. And to speak with the words of your Minister of Health yesterday, as a policy maker, without data, we can make policy. So the good news of that is that we told him yesterday, Minister, we are going to help you for you to get the data so that you can make your policy and that you can follow. And it is not only looking at the dementia part or the dementia affected condition. It is also looking at maybe the person also has diabetes or another NCD or another complicated story that we have to address. I told you I'm not Dr. Cayetano, but indicators of disability and dependence. Well, how many people are actually with dementia? When you have a physical disability after a car accident, everybody will see that. But when you have a dementia disability, it's only when you deal with the person and you see the mix-up or the strange things, then you will know it. Now, some people get a label after they get a diagnosis. But from the 10 persons in the low and middle income countries, only 1 has a diagnosis. In the rich countries, it's a little more, but still, even in the rich countries, most people are not getting a diagnosis. There is a convention for the rights of persons with a disability. In that convention, countries have committed that they will give support to the person with a disability, for the caregiver and all of that, but as long as our persons with dementia don't have a diagnosis, they cannot fall under that convention and actually the protection that is in that. So that is where we have to lobby that our persons with that disability, that they also can be taken into consideration for their rights. So that is where we right now can help to define what should be done and what should be in the plan for us to be considered, for us also to get support and for also to be respected. So that is the good news now that comes with the WHO, the WHO Dementia Plan. The additional details I will concentrate upon because of the time. And so the vision, just as the APAHO is identical, we see a world that dementia can be prevented. And we would like to see the people with dementia and their carers, for them to live well and receive the care and the support that they need, so that they can fulfill their potential with dignity, respect, autonomy, and equality. So the goal is the same also, only the time frame is different. The WHO plan starts since Monday last year and is going till 2025, whereas the PAHO plan started in 2015 and ends in 2019. But it is the same content. Improve the lives of people with dementia, their carers and families, while decreasing the negative impact of dementia on them as well as on communities and countries. So the addition that comes to the principles that we already saw with the PAHO plan is especially number 5. Universal health coverage was mentioned in the PAHO plan, and the WHO said, and social coverage too. And I know, as a caregiver, how welcome that can be, so that you can have more income facilitate others to be paid and to assist you in the care for your loved one. So here you have the strategic actions that are proposed in the PAHO plan and the WHO plan. Actually, you can say they overlap one another. But the good news is that the plans of the World Health Organization are very detailed in terms of what should the member state do, what should the governments do. That's the first column. What should the Secretariat of the World Health Organization do? And what can we as partners do? The good news is that the Minister of Health yesterday already took out his hands and offered his hands to partner with the Alzheimer's Association here. So if you are not yet a member of the Alzheimer's Association from Trinidad and Tobago, you see that table there, please give up your name and become part so that you can also be there to receive whatever comes out of that partnership relationship that starts now with the Ministry of Health, but also that you can give your input that can be channeled to the Ministry of Health. So to strengthen the Trinidad and Tobago Alzheimer's Association, but all the other ones that we have in the Caribbean, that's very needed so that the priority can be addressed for dementia. So that we can actively participate in the policy making and that we can support the implementation of the dementia plan. To promote awareness, dementia friendliness, human rights and equity, to promote inclusion, don't leave us out, and engagement and support the implementation of dementia awareness and dementia friendliness in our society. Yesterday, we heard the news that one of the persons that was invited to come to this meeting, person with dementia from Barbados, when she arrived at the airport, they told him that she had to take off the shoes. And the person didn't want to do that and got so confused that she lost the plane to be with us. Dementia friendliness from the society is so important that we can understand such a person. And yes, we can have all kinds of security rules, but we should have security rules to protect the person with dementia too. And this is where even such a little example can show you how important it is that we can influence what policy and what society should do. To reduce the risk to get dementia, we will be partnering with the Caribbean Health Coalition, because that is very important too, that we can prevent other peoples to get dementia too. Provide evidence-based, user-friendly information. If we want to know who is having dementia, who is developing dementia, in what stage of dementia, we need that they are tested, we need for them to be followed, and we need for them to get a proper treatment. It's not one size fits all, give them this drug and that's it. No, we have to demand that we get proper treatment and that we get also proper care. Support for the dementia caregivers, to promote for the caregiver also, and the protection of their rights. It's not only the person that has dementia. The person that is a caregiver is also a human being, has the same human rights, must be helped, must be protected, and must be empowered to speak out, say what you need, say what you want to get your assistance. And also to provide them with more training so that they can better give their care. The global targets that have been set, that's done for government, but also for us to monitor. I will leave that for you when you have those slides. The organizing committee has your email, so digitally we can provide you with that. Then what is the conference team? No time to lose. Now you will know why. The PAHO mental health advisor says the time frame of the strategy is 2015-2019. So not much time is left, and time is of essence. Every 2 years, the PAHO Directing Council discusses the evaluation of the PAHO Dementia Plan. So today, to September, when they're going to discuss it, what is it that we still can do? So maximizing the opportunity for Trinidad and Tobago then, particularly, this minister must go to the PAHO meeting in September, and he must bring something there to the table. None of the 32 non-Latin Caribbean countries has a national development plan. So there's no time to lose. Finally, the Caribbean. That's the world region with the highest prevalence, which means to say that of the 100 people, there are more people getting dementia in our region than elsewhere in the world. And it's accelerating increasingly. You would like to know why, just like me and Dr. Cayetano. So she provided this slide. You see all these regions of the world. The two red ones. The last one is from Latin America. And the Caribbean, look at there. Over 8 of every 100 persons developing dementia at this moment. These are the stats that they have. So if we are the region with the most persons getting dementia of every 100, that's a very powerful, effective reason for us to do something. And we can't wait for other countries to do it for us. We have to do it ourselves. So the numbers are increasing, even for the Americas. But guess what? When you look at the blue indicator, it is doubling the amount of persons from 2015 to 2030. But when we look at the Caribbean, it will be more than doubling. These are already projections known. So it's even worse than you have thought. The Caribbean region will have the highest acceleration increase of persons with dementia. Based on estimates of Alzheimer's Disease International and the research done by the 1066 group, you see in 2010, they already counted and estimated that 328,000 people in our region. In 2030, it will become 606,000, and in 2050, over 1 million. In other words, this is dramatic, the increase, because we know already that for HIV/AIDS, it is coming down. And that got all the attention of our governments. And as the minister yesterday said, if we got the money to come up with a plan to address in PANCAP the issue of HIV/AIDS in our whole region, then we can do that for dementia too. So with that good news, for any questions, here are the details for you to reach Dr. Cayetano. And I want to thank you. Here you have my contact details too.
Thank you very much, Dr. Raymond Jessuren. I can't believe that Dr. Cayetano was not here. You did such a wonderful job of presenting her words and again helping us to recognize why we are here and why your input in this afternoon session is critical at this point in time. You are in the driving seat. You have an important contribution to make to changing policy or identifying what policies need to be implemented. And so your voice, your words need to be recorded in the activity that we have this afternoon. So please do not think about not turning up after lunch. Thank you very much.
Thank you.
I'm just looking at the program and keeping in mind, I know that the hotel staff is also working. Mrs. Claffrey, are they ready for us outside? Almost like 5 minutes, almost like. So ask them if they, we have another speaker scheduled for this point. It's now 10. Angela, 10 minutes? 5 minutes? 10 minutes? We were supposed to have Angela and her mom, and she will explain why her mom is not here. We were also, as Raymond said, we were supposed to have another person with dementia. So it's really important in a session like this that we do not exclude, and we were very conscious of that, so we made a great effort to to have persons with dementia present to you, but as Raymond explained, one person was prevented from coming onto the plane, and now Angela will let us know what happened with her mom. Thank you. Thank you.
Hi, good morning, everyone. I have to apologize for my mother not being here. I have spoken before at other small conferences about dementia, and my mother, when she's lucid, I realize it hurts her. She feels that she has become a burden on the family. And because I'm going to speak now and a little more in depth, I really don't want her to hear these words, because I would never want my mother to feel she's a burden on this family or anyone. She has been a caregiver herself until she's come to this point in her life. She was a nurse for all her working years. She's been a devoted wife, a devoted mother, grandmother. And in her lucid moments, she realizes when I speak how much weight she has become. And it hurts her. And we end up with a session of crying and having to reassure her that she will never be a burden. So that's why I did not bring her to this morning. However, it's a pleasure talking, and I feel I have to speak out because I am, as my father said, a pseudo caregiver. He is the primary caregiver. Because of my job, I'm not always around. But when I am around, it has become a quite challenging job. My mother was diagnosed in 2012. It started with a few incidents that we would laugh off. You know, you're forgetting where you put your keys. You're forgetting what happened yesterday. And a few incidents, and the last incident that caused us to realize that something was seriously wrong was my mother is a fashionista. She likes to do her nails, she likes to do her feet, go for pedicure and everything. So I'm accustomed dropping her by the place in Woodbrook. And I dropped her by the gate and left her. She went inside, saw a hole in the wall, and thought it was a doorbell. Took her stick and decided to push it into the hole. This place is air-conditioned, so they didn't hear her. Of course, nobody responded, and she left. Now, if you know Arapita Avenue, it's a very busy street. She walked up to Arapita Avenue and was completely lost. Standing up there, having no clue what to do. Thank goodness we still have some good people in the world. A stranger stopped and asked her what was wrong. Then a family friend happened to pass and found out, and then they called us, and we realized, oh my God, something is wrong. So we mentioned to the doctor. Doctor said, well, take some tests, and the test proved that she had early dementia. And I'm saying in my mind, oh my God, if this is early dementia, what's going to happen later on? Because it was shocking. I've never heard about it. I've never been involved in it. And you always think it happens to somebody else. It never happens to you and your family. All right? So we had to find out and start to learn what is dementia. What do we have to do? How do we handle it? And that has been a chore and a journey since. First place we had to do is what do we do with my mother? Because I have to work. My father, who is the primary caregiver, does not have the patience. You can't go down to the grocery and buy patience. Patience doesn't exist. Thank goodness we found a place, JNC across there, and they deal with dementia, because not all facilities in Trinidad and Tobago deal with dementia people. All right? So that was a great thing. We got her settled. She loves it. But that's only 8 to 4. I came home from work one day. My father says, oh, I fell out of bed. I said, so what happened? Your mother did not even react. No, oh my gosh, are you okay? What happened? So we then had to get help on weekends. Why I'm saying all this is because you have to have money. It's an expensive disease. Is it a disease? I'm not sure. But it's an expensive condition. You have to have help and support. And it's not always available. I had some friends live in Point Fortin, which is deep south. They have no facilities like JNC. The helpers she gets are not trained in dementia patients. Yes, you can get nurses' aides and nurses, but not everybody is trained. So every minute she was changing helpers because her mother's personality changed so much, she got very aggressive. So everybody was leaving. Because if you can't handle your family when they're aggressive, how do you expect a stranger to handle your family? All right? So she had no facilities like that. Thank goodness we had. But this is up in the west side of Trinidad. All right? Sorry. I get very emotional when I talk about it because I've seen so many of my peers and my friends said this is a time where all our families and all our parents seem to be getting something. But dementia is a very hard thing to understand. And I still don't understand it. And I get angry. It's a whole set of emotions. I get angry. Then my mother cries, and then I feel sorry. And then we just have to go through this whole cycle again because I'm seeing this big, strong woman who was a nurse, who carried the whole family, now like a child. And I have to be the adult for her. And it is very, very painful to see. And then I have to also be concerned about my father. And every time I think about it, I feel selfish because I have to work. My father is retired. He was having headaches from the stress of looking after my mother. And to get him to go to the doctor was like pulling teeth. Eventually he went and he got MRIs done, CT scan, all kind of things. But it just said it was stress. So my biggest fear, I have this thing. We have an alarm in the house. So at night my father will put on the alarm and in the morning he will take it off. So when I get my beep on my phone, I know he's still alive. All right? Because I know he's awake and he could look after my mother because I don't know what I'm going to face when I come back home from work. All right? And that is the thing. Because my family is very small. It's just me and my father. My brother died 2 years ago. My son lives in the States. So there's nobody else to call upon for support or for help in case something happens. And though people do try in the facilities that they offer, they're not for dementia people. They're not for dementia persons. All right? So where do I look for help in case I need help? What do I do? I ask myself that every single day. I love my mother to death, though she drives me nuts. All right? But that is who she's become. And I have to learn to live with it. It is so hard. And I'm not going to lie, I would not wish this on anybody. All right? I talked to my colleagues because another colleague came up to me. She said her mother was doing X, Y, and Z and giving away money and doing this. I said, your mother sounds like she's having dementia. No, man. She has no... Yes, go and get her checked out. She now in a $7,000 home. $7,000 a month is a lot of money. But she has to put her somewhere. Right? She's not getting the care because most of these homes, sorry to say, don't continue stimulating the mind and stimulating the person. All right? But she has to put her somewhere because she has to work. And that is what people have to face. I can't afford to stay home. But I'm sorry to say, I don't want to stay home because I know I don't have that kind of patience and skill. I watch people like in JNC and the helper we have, they have serious patience. And I applaud them for it. And I thank them every day for it because it gives me a chance to have some kind of a life and my father a chance to rest. He doesn't want a life. I tell him go and do something, go out. He feels guilty for going out because his wife is not there with him. All right? So that's all I have to say, and God bless you all for trying to do something. I know it may not happen in this lifetime, but at least we can look forward to something in the future. So thank you, and enjoy.
Thank you very much, Angela. You know, when we talk and we heard wonderful speeches telling us about this, that we need to have the dementia plan, then it means that it's for people like Angela and her mom and her dad that we are going to be doing this work this afternoon for. We have to make sure that you keep that story, and that's why it's important that we put that on the particular record, that we heard those stories. Now, we're running a little behind time, but I thought it was important to hear Angela's story before we broke, because we all have our personal stories. Once you have somebody touched by dementia, you have your personal story. When we come back, we have a panel discussion, and we will tell you who is on the panel. We've added a couple people to the panel. Let us try to be back in the room by about 10:35 so we can get started right away. Refreshments are ready. They're ready for you. Go quickly, have some refreshments. And when we come back, I will ask the panelists to be seated on the head table. I will quickly introduce them, and we will get an opportunity to hear their perspectives on the challenges. Have a good break. See you at 10:35.